We will be starting with our first session for this morning on nutrition and critical care, moderated by Dr. Ghadir Al-Shumri from Saudi Arabia. Our speakers for today will be Dr. Ashraf Al-Houfi from the United Arab Emirates, Dr. Muna Hashim from the United Arab Emirates, and Ms. Samira Al-Abrawi from Oman.
Bismillah. We will start now the session of nutrition and critical care. And I hope everyone, inshallah, will come from break time to enjoy us now. We will start with Dr. Ashraf Al-Houfi. Dr. Ashraf, a graduate of Alexandria Faculty of Medicine, 1984. with an honor master degree in chest disease with critical care, subspecialty 1989. Dr. Ashraf will talk about the title of nutrition and critical illness. Kindly, Dr. Ashraf, start, and you have 20 minutes to complete your lecture, inshallah.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for the introduction. And in the next 20 minutes, I will be talking about nutrition and critical illness. And I will be trying to cover a few important messages from the current guidelines. And the two guidelines which I will depend on is the ESPEN, which is the recent one, which is published in 2018, as well as the previous one published by the ESPEN in 2016 with its updates in 2021. What is important to say is that for a long time, we used to consider nutrition as an adjunct. It's not very important, particularly in critical care. We have too many more important things to do other than nutrition, which is definitely a very wrong concept. We now know that nutrition is a therapy. It's not just a matter of you're going outside for an eatery. It's a therapy because it affects your life. It affects the metabolism. It affects the oxidative cellular and immune response. And it definitely has a great impact on both morbidity and mortality. So nutrition is integral, not only to the medical management, but also for critical care. In critical care, we used to think that we are saving lives. So nutrition should come take a back seat. It is not that important. Now we know for sure that is an integral part of the critical care management. And that's why the initial recommendation, which is quite good, that anyone who stays in ICU for 48 hours or more, he is high risk. High risk, this means if you don't attend the nutrition aggressively and early enough, there will be consequences, which is very important. Anyone has to be assessed clearly once they are the intensive care unit. The important point about nutritional assessment that it was almost forgotten in ICU. If you go to intensive care, we are always monitoring the hemodynamics, we are monitoring the respiratory status, we are doing the ventilatory structure, we are monitoring the infection, we are monitoring the antibiotic use, but no one is doing nutritional assessment, as if it is not very important. As I told you, we thought initially that we are saving lives, and then the concept was just save the lives and then feed them later. Now we know for sure that that's not a good concept. We have to do the nutritional assessment the minute the patient lands in ICU. What kind of assessment you want to do, it is not that much important, but the guidelines have recommended few tools to be used, like the NRS and the Nutric. So why I will talk about those two? Because there is a big difference between them. The first one of them is important because it is really nutritional driven assessment. You are asking 3 or 4 main questions. If the answer of any one of them is yes, then you need further assessment. So if the BMI is abnormal, or if the patient's having a significant weight loss, or there is a change in the food habit very recently, if the answer is yes for any of them, then further assessment need to be done, and then a score need to be put. And if the patient scores 3 or more, is high risk. What high risk? High risk, this means once the patient is a stable, nutrition has to be started right away. There is no way that you can delay this. So what is this Nutric score, which has been provided by the Canadian group led by Derek Haaland? You know, Derek Haaland is an intensivist. He's not a dietitian. So you will notice from this assessment tool that it has no nutrition in it. Look at the assessment tool. It's all severity assessment. It's about the Apache score, the number of organ dysfunction, inflammatory marker. There is nothing here about nutrition. So the difference between NRS, that it is diet and nutrition driven, but the Nutric score is more of a severity driven. But if you put them together, it's not bad. Then you know that the high risk is also at a high severity of illness. This means the nutrition became more important. Why nutritional assessment is important? Because as you can see, look at the difference between the complications. People at high risk of nutritional problem are always associated with more infectious complications, non-infectious complications, and they stay longer in the intensive care unit. The second important message which we want to talk about, if you want to assess the requirement of the patients in the intensive care unit, to how much calorie you want to give them. We know that critical illness is a high catabolic demand, but we don't know how high. We don't know how much should we put over the resting energy expenditure in order to cope with this metabolic stress. We don't know. That's why it is consistently required by all guidelines, and this is consistent across the Atlantic, so European, American, Canadian, everywhere, that you need to use the indirect calorimetry. For how long this recommendation was put in practice, I think it's almost 100 years now, but when you look into the clinical practice, you don't see too many people using the indirect calorimetry. We are the biggest hospital in Dubai and we don't use it. Other biggest hospital in Dubai, they are not using it. Government and private hospitals are not using, despite it is a consistent recommendation since very long time. That's why the ESPEN guideline this time in its recent edition said, okay, if you don't want to use the indirect calorimetry, why not to use the component of the respiratory quotient, which is the oxygen consumption, as well as the carbon dioxide production. So if you measure the oxygen consumption, well, we cannot measure the oxygen consumption unless we put a pulmonary artery catheter. We stopped putting pulmonary artery catheter for almost 20 years now. We don't do it anymore. So the only remaining option was the volume of carbon dioxide production. That's an easy one because any ventilated patient, I can measure the end-tidal CO2, and there's a small equation. I can say that this is the carbon dioxide production. I can multiply it by a constant factor, then I can know. So why this is not utilized in ICU? Because I can change the end-tidal CO2 by changing the ventilator setting every day. Then it will never be accurate because the carbon dioxide production, I can control the end-tidal CO2. And that's why if we are not able to use the indirect calorimetry, we go back to the standard way, which is the weight-based calculations. But if you notice at the recent weight-based calculation, you will notice that it is a slightly less than before because we realized that calories are not that important at the initial part of the critical illness like what we thought before. We thought that calories are very important, but we did not realize that the body is producing its own calories by the time of critical illness during the catabolic state. So the initial requirement of calories are not that high. That's why it has been written, as you can see on the lower part, 20 to 25. We used to do that, and we used to add what we call the risk factors. We thought that people who are at high risk need a higher calorie, and this is true, but it is not during the first week. Because during the first week, the catabolic rate is very high and the body is producing excessive energy production. Then you need that when? Not after 5 to 7 days. So people who have a major trauma, major surgery, burn, they will need to add the risk factor to increase the caloric requirement, but later, after 7 days of the initiation of the critical illness. So what is the next message is start enteral nutrition as early as possible. What is as early as possible? They said choose 48. Well, I consider 48 as too long. It is within 24 hours of patient admitted to ICU. If the patient is, look at my note by here, fully resuscitated. What do you mean by fully resuscitated? Because once the patient is resuscitated, his tissues are well perfused. So his gut is well perfused, then it can utilize the nutrition. So Spend your initial time resuscitating your patient, 6 to 12 hours. Once the patient reach a stable condition, even on pressors, this is the time you have to start the nutrition. So start enteral nutrition in critical illness as soon as possible when the patient is fully resuscitated. Now, can I delay a little? Yes, I can delay, maybe for 24 hours or more if the patient's shock is still persistent. A patient with a blood pressure of 50/30, while he is still under heavy resuscitation, his gut is not receiving enough blood. So if you give this gut more nutrition, you need more blood. You don't have blood. Then you do not start rushing and flushing the gut with nutrition while the blood supply and oxygen supply is not good. So if the patient shock is still unstable, that's not the time to start the nutrition. If the patient is severely hypoxic, now hypoxemia is an important integral factor in the tissue perfusion. If the patient is hypoxic, your primary priority is to improve the oxygenation, because tissue perfusion means blood plus oxygen. If you don't have both going to the tissue will become anoxic, and anoxic tissue go to anaerobic metabolism, produce more lactic acid. So if you increase the nutrition to full, while a patient is severely hypoxic or hypoperfused, you're actually causing more damage. If the patient is having massive GI bleeding, there is no point on starting the nutrition now, because you need to stop the bleeding first. Otherwise, the patient will become in danger. Things which compromise the abdominal and tissue perfusion, like abdominal compartment syndrome or bowel ischemia. You cannot get someone with intestinal ischemia and give him full enteral nutrition, because enteral nutrition going to the intestine needs more blood. And if the bowel is ischemic, the more blood you need, the more ischemia you generate. So those cases, you need to make sure that they are well perfused. If you have a high residual volume, which means you have a very much dilated bowel, severe paralytic ileus, you have to do something to control it before you give the patient the full nutrition. If you have a high output fistula, you cannot give enteral nutrition above the fistula. You give from there, it will come out from the fistula. Then you have to go below the fistula if you want the nutrition to be okay. So once the patient is hemodynamically stable, even on pressure, you can start the nutrition. So somebody is telling, your patient is on norepinephrine. How come you start nutrition? No, he's on norepinephrine, but resuscitated and perfused. So the word to use here is stable on pressures, tissues well perfused, meaning lactate is not rising, tissues are well perfused, so you can give the feeding and you can gradually increase it, because it is very important. Sometimes we delay unnecessarily a nutrition in critical illness because we don't hear the bowel sound. So, okay, no, bowel sounds are large intestine bowel sounds. It's not a small intestine bowel sounds. So do not wait for bowel sounds to start the nutrition. You have to start the nutrition to stimulate the bowel sounds, to stimulate the intestine to receive more nutrition. That's something which is essential. But start gradual, increase it gradually, and monitor the tolerance. That is the secret. You have to start at low and you go gradually up, which is very important. Majority of our critically ill patients can tolerate feeding in the stomach. Yeah, we know that the post-pyloric feeding is good, but the majority of them will tolerate the one in the stomach. So what if we have a problem in giving the feeding to the patient in the stomach? We can do few tricks. You can give that nutrition in a continuous mode, 20 ml per hour, 30 ml per hour, 40 ml per hour, 60 ml per hour. So it's a 1.5 liter, but giving gradually. So the amount going to the stomach is small. The amount related to the stomach is small. So you will improve the tolerance. That is one way. You can use prokinetics to stimulate the intestinal motility, and it will allow the nutrition to be okay. If not, then you can go to the post-pyloric. You can push the NGT a little down the road in order not to have a high residual volume. Sometimes diarrhea is irritating, and doctors have tendency to stop the feeding because of the diarrhea. Don't. Osmotic diarrhea can happen. You can use mixed fibers. You can use peptide-based formulas. It can help you, but never stop the feeding because you're not able to improve the state of tolerability, whether it is the gastric residual volume or the nutrient. Do something to fix it, but do not stop the enteral nutrition. Everybody is stopping nutrition whenever there is something. Patient is going to do an ECG. Patient is going to do a CT scan. Patient is going to stop nutrition. Doctor is going for a break, stop the nutrition. The only thing we do is automatically stop the nutrition. So we think we're giving optimal nutrition, and by the end of the day, you look at what is being given, you find that you don't even achieve 60% of what is prescribed. Why? Because we automatically stop the nutrition too much time. You put for the patient 60 ml per hour, thinking that the patient will receive 1.5 liter per day, but then you realize that your nurses are stopping the nutrition for 6 hours. I don't know why, but it is like that. So we give 18 hours, and then they stop the nutrition during the nursing care because they are afraid that the patient will regurgitate and vomit and aspirate. So they stop it. So you put 60 ml per hour, aiming for 1500 ml per day, and then you find at the end of the day, you give only 1 liter. So you don't give the exact amount of prescribed nutrition because we automatically stop the nutrition for unknown reason too many times. We accuse enteral nutrition of being a cause of HAP and VAP. That is wrong. Enteral nutrition is not the cause of HAP or VAP. We are, because we do not pay attention to raising the head of the bed up. Now you know that there's an NGT, and that NGT is going through the gastroesophageal sphincter. This means that that sphincter is not closed all the time. It is now patent all the time. So if you keep a lot of feeding inside the stomach and then you put the patient flat, there is a very likelihood that some regurgent will go. And if the patient is not conscious enough, he might aspirate. So enteral nutrition is not the cause of increased HAP and VAP. We are. So we have to keep the head up because this is always good. Too many people is telling, enteral nutrition is difficult to do, difficult to manage, difficult to progress. Start parenteral nutrition. That is not the recommendation. The message is very clear. If the patient can tolerate enteral nutrition, then it's number one. You do not early start parenteral nutrition. So if your patient is not at a high risk of malnutrition or already malnourished, you don't start parenteral nutrition unless 5 to 7 days. But if the patient is absolute contraindication for enteral nutrition, and he is as well at high risk or already malnourished, then you need to start the parenteral nutrition ASP. So how much? I said indirect calorimetry, this is the way to do. If not, aim to start low and gradually progress. Why start low? Because in critical illness, there's a lots of things going wrong in your body. So don't challenge your body with too much nutrition initially. So day one, start with what we call trophic feeding. Oh, whatever you want to call it, hypocaloric, and this, I don't want to discuss this that much, but start low and increase. So in day one, fully resuscitated patient, even on norepinephrine with a stable lactate, you start at 20 ml per hour. And then the next day, if there is tolerance and everything is good, we increase it to 30. We increase it to 40. We increase it to 60. So by day 3 to day 5, I give full nutrition without jeopardizing the patient problem. It is something which is important. Protein. Now, I have separate lectures about protein and lipid in critical illness, but it is very important to know that protein is more important than calories in critical illness.
Efficient preceptor, how can I achieve the learning needs of the students or the intern, and at the same time, what will be my reward, and how can I utilize their time to help the dietitians in her routine work, whether in the nutrition assessment or whether developing a new protocol. And this was also raised by Dr. Ashraf, that there should be a protocol in the critical care unit, and also for the pediatric, for the new diabetes comer. Why we don't have a protocol in our in your in all the hospitals for any kind of medical and nutrition therapy? And at the same time, we started doing this in University of Sharjah, that to provide appreciation certificates, of course, and to find a kind of tokens and another kind of appreciations, as I told you, to all the dietitians, the preceptors. They are devoting their time. Sometimes, by the end, the dietitian, she's a human, and at times she wants to sit, and she doesn't want someone to be accompanying her, but she's obliged she has intern. Okay. One of the limitations of the study was, yes, the number. So maybe we have to do another run for this study. So whoever is here who participated in this study, my deep appreciation on behalf of the group. Also, my gratitude goes to Dr. Haidar Hassan, who was a co-supervisor. Our graduates, Ahad Tudomoro, she has the DHA license for eligibility. Ashwaq Al-Mazrou'i, she's already in the public health. Linda Tamer, she is in the, she will start her master's in UK. Salwa already, Osama already in the diabetes management. And Suzanne, she's a research assistant with me and with my, in the department. And Sarah Alwari, maybe she's famous for, she's a famous blogger. Hayadit, deviated from the nutrition. And thank you, of course, for listening to me and being patient. Shukran, Dr.
Okay, thank you, Dr. Mona, for your presentation. The very important result, 97.4, that is in our female. Because maybe, depend on the, courses or the bachelor program in the universities. In Saudi Arabia, we open for male and female, and maybe in some countries just for females. I think, I'm not sure, but we will discuss about it. The new dietitian needs 3 parts: knowledge and skills, and also to do practice, which is not available for our generation before. But please, nobody asked me about which the year of my bachelor degree. It's very old. Now we welcome Dr. Samira Al-Brawi. Dr. Samira is currently the head of the clinical nutrition department at Khola Hospital, Oman. She has graduated from Sultan Qaboos University with a bachelor in human nutrition and master's degree in nutrition science. She worked in I think she will talk about the nutrition support in bird. Dr. Samira. Okay. Welcome, Dr. Samira. I have 20 minutes.
Good morning, everybody. I would like, really, I'm so happy and glad to be here in this international conference. And I would like to thank Mrs. Mona Shammar for inviting me to be transmit my practice in terms of the barn. Well, before I start, I just want to tell you the story that I had during my journey here to Dubai. While I was traveling, all of a sudden, with my husband, he received a call from his job. He had to return back to Muscat. And I was about to just, in Sohar. I don't know if you know that area. Then all of a sudden I have to decide whether to go back or to continue for this conference. I decided, and for the first time, to drive alone to Dubai. So really, I feel that I'm so happy. Well, so now we'll talk about nutrition in barns. Nutrition is very critical, having a very critical aspect. And we do have to provide a concern for it, because patient who's having like in a major burn, they are susceptible to lose a massive amount of weight. So that's why we have to do a concern regarding nutrition. Maybe a few of you encounter regarding patient nutrition, I mean like cases of burn, not because we don't have these accidents. We do have it, but actually those cases are admitted in unique centers and with supervised with specialized team. Look at this, map, World Health Organization. They just, reported like, a newly case around 1.3 million globally. So it's really a huge number. There are a lot of causes of burn. One of the causes which we have it's in a common in Oman, Shua. Have you heard about Shua? It's created a big hole, and usually in an Eid time, And most of the time, the people or children, when they play around, they just fall inside that hole and they get burned. And also there is a lot of causes. For example, like we'll have Alzheimer patient in the summertime, they just go away from the home and they cannot return back. So they have a fraction burn, and sometimes it causes even leads to amputation because of the. Before we in this slides, we do have like little bit picture. If you cannot see it, then you can close your eyes, okay? But it's a simple one. Before we go to the nutrition intervention, I would just like to explain for you the degree of the burn that we have it. The first and the second degree burns not needed the massive intervention regarding the nutrition. And the most of time, these two types, it has a severe pain. But the second, third degree burn, it doesn't have a severe pain because all the nerves get affected and usually characterized with a white in color, okay? And here we have to provide a nutrition intervention. The fourth degree burns usually penetrate to the bone. Well, why we need to have and focus regarding the nutrition? As you can see this trajectory, the hypermetabolism is shoots up, and it considered the highest metabolism for these cases. Among all the kind of the diseases and the skeletal trauma, the burn, situated in the highest curve. Why we have to intervene? We have to understand for the beginning how the important that we have to intervene for the patient in terms of the nutrition. One of the cause is the patient when admitted in the burns, immediately they get like fluid resuscitation, and later on we might need for the skin grafting. After the skin grafting, like the patient will end with a septicemia. Again, multiple recurrence of this surgery. So that's why if we understand the image and the need of the patient, more effort we can provide it for patients. As Dr. Ashraf said, patients who undergo with 30% of muscle loss, they can end with a severe infection, whereas 40% muscle loss end with high mortality. Now let's speak about nutrition therapy for patients. For a patient who's having like a burn, the first thing we have to do is assessing the weight before even the fluid resuscitation. Because once we enter the fluid, the patient will have edematous and will have the bias regarding the weight. Height as well is important, and that determination of the total burn surface area also is important. With the determination, you can encounter the medication plus calculate the calorie requirement for this patient. For timing of for the initiation of the feed as well is important. As Dr. Ashraf, he said, if you have to start it as soon as possible. But it's preferable for patients to have a burn parallel with the fluid resuscitation, because with the hypovolemic, it's susceptible to get the JR tracts, like in edematous, and later on will having peristalsis. So we found that the more that we delay the feed, the more feed intolerance we get it with a patient with burn. So this is the recommendation of the guidelines. ASPEN guidelines recommend to feed the patient within 4 to 6 hours, while American Burn Association as soon as possible. Well, when we come to calculate the calorie requirement for patient, we're gonna, get confused, which equation to follow. But every equation has disadvantage and advantage. The golden standard one is to use indirect calorimetry. And absolutely, we don't have it. Then the second gold is to use the Toronto equation. For obese patients, provide as much as possible, like, hyper calorie. And this hypercalories is calculated according to the ideal body weight. It means like less than 70% from the ideal body weight. Protein as well, it's very important to focus on it. Not only to focus on calorie requirement as well in the protein. If we just provided high protein and low calorie, especially with a burn, not any other cases with critical ill, with a burn and with high, a trauma, what will go on if we focus the calorie, the protein which is provided for the patient will go to release energy rather than going to build a new tissue. So focus to give higher calorie and higher protein as well. Protein requirement 1.5 to 2 grams per kg. I would like to highlight the glutamine. Have you heard about glutamine? Okay, it's really a common amino acid that you need to be supplemented for a patient who's having burn. Why is that? It's because everybody here in this room can make glutamine, but patient who's having inflammatory response, they cannot make it. So we do need to supplement it. It preserves our GI tract integrity. As well, it helps to create the antioxidant, which is called like glutathione. And I would just want to tell you a story about glutathione. When I was, in a cosmetic shop, I have found that a soap called glutathione. Immediately, I just took it because I know the importance of that. It's usually initiate and synthesize the new skin. The contraindication for that, patient with having liver disease or renal supposed to not be given, and the doses as per ESPEN guidelines supposed to be given 0.3 here. 0.3 to 0.5 kilogram per kg. Have you heard about HMB? Ask GPT chat, will answer you. Okay, hydroxymethyl this slide I have adopted from the Professor Kala when I attended the conference of ESPEN last month with Salah and Sana in Las Vegas. She highlighted the HMB, hydroxymethyl that it's very important to be supplemented for a person who is having burn or trauma. It helps also for a muscle mass and also muscle function. Vitamin B complex, also one of the important vitamin, is a mandatory for a patient who is having burn, a major burn, to be supplemented. Why is that? After the burn, immediately the patient, undergo with a lot of complication. In between also, like, organ dysfunction, as well metabolize of the carbohydrate and fat. So the B complex help to increase metabolism of the carbohydrate and release energy so that can be used to generate the new tissue. Vitamin C, I call it a beauty vitamin for all ladies. Focus on that. Why is that? Because it's the main vitamin that help to generate a collagen at the new tissue. So supplementation also for patient who's having burn trauma, it's mandatory, has to be supplemented. This is the sources from the intrafeed that can be prescribed for patient. When if any dietitian has to speak with patient, try to educate the patient what is the importance of the vitamin C. Fine, when you take like around half cup of guava, you can take around 888 milligram. Every single person here needs from 80 milligram to 90, but patient who's having burn, about 200 milligram. There is a big challenges when you start to feel the patient who's having burn. What are those challenges? Patient with burn always faces nauseated, and always we have to encounter medication to be given like metoclopramide. As well, fasting in between, because of the surgery. Plus, like delaying the feed because of the dressing. So try to tell all the dietitian and all multidisciplinary team what is the importance of the nutrition intervention. If we just ignore that, the patient will end with catabolism or decreases of the muscles of the body. So here is the nutrition intervention is only the important thing to focus on? Well, if the is nutrition only thing that will stop the catabolism for this patient, no at all. We need other 3 factors in between to stop this catabolism. One of the factors is we have to provide a surgery for them, like a skin grafting earlier, to not be delayed, because sometimes the patient, they refuse surgery totally. So we have to inform them what is the importance of the surgery. Exenterilone is a steroid medication, plus early rehabilitation. Well, patients are not created equally. Every single patient have a different characters. So always when we just decide and recommend the nutrition intervention, It has to be individualized, you know, and to not follow the guidelines blindly. Here, we're going to start to, you know, giving my practice in the burns. The one who cannot see the picture, you can close your eyes. And the ladies who are less than 18, also close your eyes. I think that everybody will close the eyes, not because they don't scared, they are scared, because they are less than 18. Yes, this is the third degree burns, whitish in color, cheesy. When you press it, there is no pain on that. You know, this we needed what to do, a screen grafting, debridement, remove all the skin, and then again harvest this normal skin to that affected area. This is one of the cases which have like a major burn, around like 80%. He had a lot of complication and organ failure. But with the nutrition intervention and with the multidisciplinary team intervention, he crossed this status. As you can see, for all patients who's having burn, we calculate the weight from the admission till the discharge and the follow-up as well. From the admission, his weight was around 68, and in between, he lost a lot of weight, around 30% from his weight. Why is that? Because some of the medication we couldn't give him, like a steroid hormone. But later on, he improved. And the good thing with a patient who's having like, you know, major burn, they can improve and become like a normal person. Doctor told him that he will have like infertility, but now he have 2 kids. This is, you know, child who's having like, you know, a skin grafting. You can see the pores, how the skin is aggregated to just spread it in the leg. Again, this is one of the a major, you know, story that we had it. 10 years old, he was, you know, burning his farm. He wanted just to get rid of from the insects, which is sprayed. We call it in Arabic al-baraghith. Yes. All of a sudden, when he put the petrol around the farm, the dad he's put that. When the white came, all of a sudden the flame created that while they were in the center of that barn. And then he got around like 95% and admitted in interior hospital. In Oman, we don't have like, you know, specialty who can do this surgery everywhere. Only in Muscat and Salalah, we do this kind of surgery. So he admitted 10 days in Nizwa, which is away from our hospital. And everybody, they were asking to transfer him to our hospital for the treatment. But our consultant and our policy, we cannot accept the patient if the survival rate is less than 10%. After 10 days, the consultant really gets surprised how this child is alive till today. And then he decided to receive him. When we received him, the journey of the treatment started. We had give him like internal oral nutrition, internal nasogastric tube, and a plus TPN. Sometimes we was using together like a TPN, a plus nasogastric tube, because sometimes we need to provide for him like in a surgery, and we'll keep NPO. So it's no matter to provide the feed, the TPN, you know, less risky than provision of the NGT. Good, after like 3 months, he didn't lose a lot of weight. He preserved his weight, okay? But he needed to transfer to abroad for a plastic surgery. In that, you know, transfusion, he lost around 20%, or sorry, 50% from his weight. And he came back with a 20 kg. He left 40 kg, and he came back after 1 month with 20 kg. Again, we started treating him with all kind of supplementation that we have, big efforts, and also we advocated him. What is the importance of nutrition? He was supporting a lot us, and he was listening. He was trying his best. As long that he has having like nauseated, but he did a great job. Also his family. You can see the picture down when he came back, and the up picture, he was little bit chubby, and he is skinny. As you can see, he lost around 20 kg. Now, he's now 21 years old. I don't know whether it has a voice here. The voice.
Study, blood, talk, frustration, and discipline.
So care do magic. Don't listen that the survival rate will be the patient will be pass away. The more care that we give, yeah, you can do a magic. In conclusion, I would like to say that nutrition intervention, it works. Do your best to let this patient survive. Thanks a lot. On time?
Stay here, please. We invite all the speakers to come here on the stage, please, to receive some questions. And before that, allow me to welcome Dr. Ali Al-Rashid, the Director of General Administration in Ministry of Health in Saudi Arabia. Also, allow me to thank again Dr. Mona Shamar and her team for organizing this conference, which is one of the important event to share our knowledge with each other and to sharing our information about. And the good example is Dr. Ashraf and Dr. Mona and Dr. Samira. Now we have just 5 minutes to receive the questions, please. Dr. Samira and Dr. Ashraf and Dr. Mona. Here, please. Excuse me. There is a question.
Thank you. Hello. My name is Hiba Musharrafi. I'm clinical dietitian from MediClinic, Parkview Hospital. And I have a question for Dr. Ashraf, please. So if from your experience, if you are dealing with a patient with a leaky gut, so how much or how far can you challenge with enteral feeding? So the rate, the type of feeding, maybe number of days, and what will you look for so that you decide whether we stop the enteral, go to parenteral, or we continue, we advance the feeding? Thank you.
Yes, fine. But let me first explain to the people what do we mean by leaky gut. If you're talking about a leaky gut, which is due to microvascular problem, so the management is always related to the sepsis management. But if you're talking about a leaky gut, which means a fistula, then the situation is different. So you're talking about a leaky gut due to microvascular failure, or you're talking about a leaky gut that the content of the bowel is going out because of a fistula, whether we are talking about a small bowel or a large bowel fistula.
No, not in case of fistula, but also
okay,
if
so
you can tell us.
The term leaky gut means simply that the patient is in a state of microvascular failure due to sepsis, septic shock, and multi-organ failure. Your primary treatment should focus on the management of sepsis, which is hemodynamic stability, improving tissue perfusion. Usually, this will take the first 12 to 24 hours. Once the patient is fully resuscitated, he will fulfill the criteria which I mentioned before. So you don't have to do anything in the first 24 hours other than optimizing the hemodynamic support, optimizing the tissue perfusion, blood pressure, hemoglobin concentration, oxygen delivery. Once this is optimized, even on a good amount of pressor support, you can start right away the enteral nutrition. We always start trophic, and the trophic is not for neither calorie nor protein. It is just to test the integrity of the intestinal mucosa. And if the tolerance is good, we gradually increase. By 3 to 5 days, we should reach at least 80% of the required proteins and calorie. If we are not able to, then some of the SPNs can be added, which is supplemental parenteral nutrition, which we never need. If you resuscitated your patient properly, give him the proper hemodynamic support, proper oxygen delivery. In 5 to 7 days, you will give the patient the optimal nutrition. After those 5 to 7 days, it will depend on the metabolic demand. If the patient is still hypermetabolic, then the requirement of calorie will be much higher. If you don't take care during this particular period, the patient will go into a dangerous weight loss in the next 7 to 10 days. So initially, there is a hypermetabolic state, which you produce few extra calories. You don't need higher calories during the first 3 days, but you need higher protein. Once the patient is fully resuscitated and you reach to 80%, take care that the next period is a replacement phase. You have to increase the calorie, you have to increase the protein requirement in order to catch up, to prevent the patient from losing further muscle mass.
Okay, thank you, Dr. Ashraf. Another question, please.
I can give you this.
I'm Dr. Zubairi. I'm a physician.
After the
I'm a physician and I'm at Al Diafa Modern. There are two words these days. One is organic products and the other one is vegan diet. How healthy are they and how they are different from the normal products? Can you give us some guidelines about their use? Are they useful at all? Thank you so much.
Yes. Pardon, you just spoke about the organ feeding. I didn't hear your voice was a little bit far.
One is the organic products,
Organic
how healthy they are, and the other one is about the vegan diets, that non-animal
Yes,
diet.
for the vegan diet, usually we provide for them and let them understand there is no supplementation that specialized for the vegan that we use it. All they need to have the protein. We provide supplementation, but in terms of the normal diet that you are taking, usually we combine diets. For example, non-essential amino acids and for example, rice and beans to get all kind of essential amino acids. We do like a combination of food. There is a special diet. Okay.
Okay, Dr. Salah.
And regarding organic, we are not using actually the standard one supplementation we provide for them. We use only from our products from Abbott and Nutrition Company. Okay.
Thank you very much. I have a question to Dr. Ashraf and Dr. Samira. In patient, let's say in high catabolic rate or patient in ICU, we have a problem of refeeding syndrome. Refeeding syndrome. So, it's very difficult, even after 7 days, is to increase the calories very high. Usually they recommend even 5 to 10 kilocalories per kg. So what is the practice in your institutions?
Yes.
Thank you very much.
Thank you again, Salah, for your question. Yes, like refeeding syndrome, we face it a lot. For example, the child that I showed you, when he came back, he lost around 20 kg. So he's having very high risk of refeeding syndrome. We provided for him 5 cal per kg per day. And then we just increasing the amount of calorie, gradually within 10 days. Plus, we supplemented him like a multivitamin plus thiamine to overcome this condition of refeeding syndrome. And we did a successful adherence there. Dr. Ashraf, if you want.
Yeah. Anyway, the refeeding syndrome is always a risk when you start to feed the patient, particularly starting carbohydrate, provided that patient is malnourished before. So my critically ill patients are normal people, coming by sepsis, coming from trauma, they are normal. They're not necessarily malnourished. So we do always the same protocol, initial resuscitation followed by trophic feeding, which is 20 ml per hour, just to test the integrity of the intestinal mucosa, gradually increase, hoping to reach 80% of what we need by day 5, which is quite good. If that patient is originally malnourished because he came, for example, from a neglected area, we found him like that, then we go further. Instead of 5, we go to 10, And the important thing is before starting the carbohydrates, which is your primary source of energy, you have to take care of the electrolytes. Our major problem here will be the fluid and electrolyte shift. And I have seen it with my own eyes, the kind of arrhythmias which they develop because of the phosphate, because of the magnesium, because of the calcium. It's usually fatal. You never know someone who's developing a torsade de pomme in front of you while he has no cardiac illness. And the primary cause of that is the marked electrolyte shift once you start the carbohydrates. So if the patient is emaciated and he is as well critically ill, we extend this process to 10 to 14 days, not to go to the 80% calorie and protein requirement early in day 5, but we postpone it a little because we are afraid that the fluid and electrolyte shift might result in serious cardiac arrhythmias.
More question, please.
Thank you very much for this very interesting session. I have two questions, one for Dr. Mona Hashim, one for Samira. Regarding the training, I am a clinical dietitian and I'm a senior clinical dietitian. I face the same issues when it comes to training students. I'm the first one who refuses training because, again, when we are graduating, we graduate not with academics, we are graduating as healthcare professionals. So teaching skills in a clinical setting is a bit different. I would suggest maybe in your upcoming project, the last semester of, before graduation, focus on the competencies before graduating, which is critical thinking. When we're in the clinical setting, we don't rely anymore on Krauss and Oxford books and so on for our management. We go to interpret data from big organizations like ESPN and Aspen. So I think that would be really good if you focus on critical skill thinking before graduating. For Samira, I know we have a gap in burn management, nutrition burn management in the GCC area. That's what, because I've been looking for guidelines. So how are you keeping up to what's new? How are you checking your references? Is the practice right or wrong? What's the monitoring skill you are following for your patient to just make sure the assessment or the nutrition plan is right? Thank you.
For the assessment, whether, always we rely the guidelines, which is a more adherence for the patient who's having burns, like in ESPN and Aspen guidelines. There is a lot of literature review and articles are really far, far away from the real practice. And always when I attend the conferences, and maybe I'm the only one who's covering burns in my country, when I attend conferences of the burn, usually I take, the contact number of the people are, responsible for the burn, and always ask about their practice. We found that our practice are a little bit near. And always when I go to the conferences and check the practice, the most of the articles that is published, it's not real practice. This is the problem. So we do have a lot of challenges to having decision. What would you decide? Whether is it the procedure that I do, is it right or wrong? We do have a big challenges. And as that currently we are working in the national guidelines, me with my colleague Sana, who's working in pediatric nutrition, and for me in adult nutrition, we found it less again for a very big gap regarding the information of nutrition in burns. So always follow what the other centers do to assess yourself whether you're doing right or wrong. Okay.
May I answer? I want to ask you why you're refusing intern or trainee undergraduate?
Said academics is a different area. Now, of course, I train, but I'm the first one who refuses. Plus, we do feel it is, as again, the reason you've entered, we're not getting paid for training skills.
They are they are over your workload.
It is over the
Yes,
workload
yes.
because we do much, we work in a hospital and so.
When we send them to the sites, that means we are emphasizing and we are acknowledging the role, the dietitians as a role models, as a motivators. Of course, we have to give them, this is integration of theory and the practice. All those theories, you mentioned critical thinking, and we're like, okay, شو يعني is critical thinking? How you are going to be a decision maker? Should his diabetic renal, what is the priority to deal with this or with this? So this is what we are looking for when they are doing this practice. Inshallah, as you mentioned, we are aiming to have a national workshop regarding the teaching skills in clinical side bed, they call it, Dr. Ashraf, side bed education, something like this.
There are some people who are charismatic, they are attractive, they can teach well, whether they have been through courses to teach them how to teach or not, but it is better that everything will be systematic. So that's
Thank you.
Okay, okay, thank. The last two or one question, please.
Thank you so much. Good morning, everyone. My name is Mariam Sheikh, and I'm a clinical dietitian from Pakistan. I do agree with Dr. Mona that there is an integral approach, the academia as well as the clinical exposure. So you have identified in your study the common barriers and the motivators for the preceptors. Since we have identified the major issue and the major barrier is not the unwillingness of the clinical dietitian, mostly throughout the world, but it's the lack of support from the administration or from the hospital HR that they do not have internship programs. So did you impose and employ any other strategies where you can abide hospitals, whether private or government, to have a dedicated internship program? Because without the clinical exposure, your dietitians cannot be skilled enough to handle the patients. Because we all know that academia is totally different than the clinical exposure.
Practice. Yeah, we started apart from this study, and this is what we are sometimes. It's a mini orientation program, which I'm doing when I'm going to start initiating a new internship program in X hospital, especially in the private. Yeah, but yes, we should do something like this.
Like as a part of ECNC, as a member of Emirates Clinical Nutrition Society, it's a big society. See, so you can like on a government level, policies can be made and implemented accordingly throughout the whether the hospitals are private or government.
Yeah,
so it should be implemented.
We aim for this.
The underlying causes of obesity in Prader-Willi syndrome is reduction of resting energy expenditure is one of the main causes. So even if the patient is not hyperphagic, the reduction of resting energy expenditure will lead to increased body weight. Also, there is elevated level of hunger hormone ghrelin. They have growth hormone deficiency, which will lead to defective lipolysis. For the management, here the nutritional management have a mainstay role, as if we diagnose the case early on, we can delay the introduction of carbohydrate in the meal, and that will lead to improvement of the weight gain or reduction of the weight gain. Also, we can give hormone replacement, growth hormone replacement, sex steroid to induce puberty, and there is a debate about the role of bariatric surgery in managing Prader-Willi syndrome. I think there is a presentation later on about the role of bariatric surgery. Then we have another syndrome, which is Bardet-Biedl syndrome. This syndrome is characterized by obesity, mental retardation, dysmorphic extremities. As we can see in this photo, there is 6 digits instead of 5 digits in the hand of this child. They will have retinitis pigmentosa, which will be present in form of night blindness or nystagmus, and they will have delayed puberty, different level of renal malformations. The inheritance of this condition is autosomal recessive, and the cause of obesity remains unknown. And for the diagnosis here, we depend mainly on the clinical presentation. And for the management, there is no specific management for this condition, but changing lifestyle, nutritional management, and supportive management for the associated conditions. Another syndrome is Carpenter syndrome. Here they present with obesity. They have characteristic malformation of the head shape due to craniosynostosis, which is mean early or premature fusion of skull sutures. They have digit abnormality or deformity, like polydactyly, syndactyly. They have congenital heart disease, hypogonadism, and the etiology of this syndrome remains obscure. Another syndrome is Cohen syndrome. Here the mutation is in chromosome 8. They present with hypotonia, developmental delay, microcephaly, maxillary hypoplasia with prominent incisors, and as we can see in the adjacent photos, they have prominent incisors, and this is mainly due to short philtrum and thin upper lip, which will not cover the incisors. Also, they have cylindrical tall fingers and toes. Another syndrome is Alstrom syndrome, and here they present with obesity, and they have neurosensory deficits like deafness, endocrinopathies, with early onset of type 2 diabetes. As you can see in the photo, they have most of them wearing glasses, or all of them wearing glasses. They have retinitis pigmentosa and tendency to blindness. Finally, we will talk about Rohat syndrome. This is an acronym to rapid onset obesity, hypoventilation, hypothalamic, autonomic, and thermal dysregulation with and without neural tumor. This condition identified recently, there is marked hyperphagia, rapidly evolving obesity, various forms of hypothalamic dysfunction like central hypoventilation, thermal dysregulation, tumors of neural crest origin in some patients. The cause and the treatment of this syndrome remain obscure, and most of cases we see them in BICU due to this combination of presentations. At the end, we can conclude that obesity is a multifactorial, has a multifactorial causes. It can be of genetic or non-genetic origin. And for the genetic causes of obesity, there are some pointers. So if you find history of consanguinity, intellectual impairment, dysmorphic features, organ or system-specific abnormalities, severe obesity of early development, especially if before age of 2 years, hyperphagia and food-seeking behaviors, any other specific features or characteristic phenotype to certain syndrome. So here you should think about genetic obesity, and it's preferable to do genetic testing for confirming the diagnosis. As we said, mostly for management, we need nutritional management, lifestyle modifications. For some causes of genetic obesity, there is a recent approved medication, and for the rest, there is no medication yet. This is an area for further studies and research. And by end of this, thank you to all of you for your attendance.
Thank you, Dr. Olivia, so much for interesting information about the obesity. It is a big challenge to deal with the obesity children or also adults. I think it is important to be the multidisciplinary team to deal with the obesity patient and to treat the patient with the obesity. We have 1 hour for the lunch and pray time. Please be on time. And don't forget to scan your barcode for each session. Thank you for all attendees.